Hi everyone, welcome back to another lecture for PS Platypus. Today I bring to you I guess, very sought after piece of anatomy that you'll be covering in semester two, which is your pelvic organs. So I know you've had a fantastic lecture already from James, who covered sort of the bony structures as well as some of the ligaments and the muscles that make up the pelvis. But now we're going to be diving a little bit deeper and looking at the actual organs themselves, as well as maybe going a little bit further back and looking at the perineum. Now, these were essentially designed to be sort of two separate topics, one for the organs, one for the male and female reproductive systems. But I've decided to combine them because I feel like there's a lot of overlap. So you might be thinking this is going to be a very big, like huge, long sort of lecture, but it really isn't. And the reason why is because I had a bit of a think before today's lecture that I made about the utility of going into a lot of detail about the specific organs. And unlike, gastrointestinal tract or MSK or cardio or respiratory, there's actually not that much that you can be examined on when it comes to very specific organs. It's more about the ideas. And as long as you know some of the, I guess, important features of the organs, it's very, very easy to get good marks for this section of the exam. So in the interest of the PS Platypus spirit of keeping things as simple as possible, but also as high yield as possible, you'll see that there's not actually that much content here. And if anything, the slides that have words on it, those are the ones that I would recommend you focus on more. The ones that have purely pictures, I think are more for illustrative purposes and just to keep at the back of your mind. So as always, if you do have any questions, feel free to message me, or if something isn't mentioned, I can create a separate sort of mini video on it. But if you do feel stuck or you feel like some of this might feel slightly incomplete, you know that you have access to the notes on the drive. So if you just click on those notes and it directs you to my Notion page, if you click on the pelvic anatomy section for semester two, you will see all of these topics, but expanded in a lot more detail, in some places more than you need to know. Okay, with that TED talk out of the way, let's just get started. So before we even talk about the organs, it's important to discuss the perineum. So remember that the perineum is sort of the space around where the external openings of the anus as well as the urethral tracts are. You might be familiar with sort of the diamond shape that the perineum makes, and the fact that the anterior section of that is called the urogenital triangle, and the posterior section of that is known as the anus or the anorectal triangle. And the division is sort of the line that's drawn between the ischial spines or something like that. So essentially, you've got these two spots. So the perineal pouches and the layers of these pouches, that's within the urogenital triangle more. And this is a topic that I've chosen to expand on because I had a lot of confusion when this was discussed in a dissection lecture. And I know a lot of other people did as well. So I guess the diagrams on the right sort of speak for themselves, especially the one on the top, which is color coded. You can sort of see that if we think about this as sort of a coronal sort of cross section of someone, you can see that you've got the blue bit at the very bottom, which is a superficial perineal fascia. Obviously, even more superficial to this would be the fat and the skin. Between so that, and then you've got the green layer, which is the deep perineal fascia. Between that, you've just got a space, right, which we'll discuss in a sec. Underneath that, you've got the superficial perineal pouch, which contains a few interesting things. Then you've got the perineal membrane, and then you've got the deep perineal pouch. So all of these are quite important. So I've started by talking about the deep pouch. So the deep perineal pouch, that's between the deep fascia of the pelvic floor, as well as the perineal membrane, which was in red or pink. That contains the urogenital diaphragm that keeps that nice and supported, as well as the external urethral sphincter. After that, you've got that perineal membrane. So it's a very, very tough fascia. It can be perforated by the urethra in males and in the vagina in females. That separates the deep and the superficial pouch from each other, as well as being the attachment of a lot of the muscles that contribute to the external genitalia, which we'll discuss. The superficial pouch is that space between the perineal membrane and the superficial perineal fascia. It contains a bunch of things. So you've got the erectile tissues of the penis and the clitoris. You've got the different muscles, as well as the Bartholin glands, which we will discuss in a lot more detail. And then you've got the actual perineal fascia themselves, so the deep and the superficial. They're essentially continuities of the abdominal fascia. So the deep fascia is just your superficial muscles. It contains the penis as well as the clitoris. The superficial fascia is actually composed of two layers. And I think it is important to know where they're derived from. So the superficial layer is derived from campus fascia, which you might recall back to anterior abdominal anatomy. That forms the dartos and the labia majora. Obviously, diatos in males, labia majora in females. And then you've got the scarpa's fascia, which is part of the deeper layer, or from collis fascia, which then goes on to form the diatos fascia. So, sometimes it can get really confusing to think about these things, but as long as you know these four landmarks and sort of generally what things they might have in them, I would recommend looking at this anatomy in 3D, because that can make things a bit easier. But even if not, these two diagrams on the side should make things easier. It's not hugely examinable, but it's so confusing that you might be a bit worried or scared. What if they ask me a question? It's not too difficult, okay? Cool. Now that that's out of the way, let's talk about some slightly easier things. So the urethra and a condition known as extravasation of the urethra. So I guess just very simply speaking, there's top two diagrams there. The left-hand side is showing the male urethra coming out of the bladder. And then on the right-hand side, you've got the female urethra. The male urethra, as you would expect, is a lot longer. This cross-section doesn't do it justice because obviously it goes right through into the penis, so it's going to be much, much longer. Whereas the female urethra sort of ends where the vagina starts, right? So it's a lot shorter. The male urethra, because it's so long, has to be divided into sort of 2 or 3 main sections, sometimes 4. But the 3 main ones are the prostatic, which goes through the prostate, the membranous section, and then the spongy section, which enters through into the penis. Now, the problem with having a very long urethra is that if you have a perforation in different parts of it, which can occur like most often because of some sort of trauma, you can get leakage. So trauma, I guess one of the classic ones would be idiopathic. So, sorry, not idiopathic, I'm getting mixed up, iatrogenic. So if you have catheter insertion and you do it wrong, you can actually perforate it manually, okay? So that's not good. So if you have it above the urogenital diaphragm, which on the left-hand side diagram is that sort of blue colored line, right? That separates the prostate from the penis. So that's the urogenital diaphragm. If it's above that, then urine kind of has nowhere else to go but posteriorly, because there's not really any space to go forward. So it enters into the rectovesical space. So between the rectum and the bladder, right? And that's a pretty fixed space, and it's a large space, right? So you're not going to get too much distension or anything like that. But if it's below the perineal membrane, which again you can sort of see in the diagram on the right-hand side, essentially what tends to cause that is you have a rupture of the spongy urethra. So the spongy urethra is the part that kind of is between the prostatic and the the spongy urethra is the part that is going into the penis. So if that part is ruptured, you get that urine entering into the superficial pouch, which we discussed previously. Now, from here, it sort of depends on how bad the damage is. So Buck's fascia, which you can sort of see in the diagram in the blue, like the dark blue, that's Buck's fascia. If that is intact, or if it's not broken from the actual damage that initially caused the urethral perforation, then the urine is essentially just going to stay within the external genitalia. So it's going to build up in the scrotum and the penis, which isn't to say it's not an emergency, but it's going to be localized. Whereas if you've got the Buck's fascia being torn, you're now just given the urine free passage into the anterior abdomen. So it's going to collect within the potential space that is around collis fascia and scarpa's fascia. So you can even have urine entering into the abdominal cavity, right? And it's all about how these things communicate. So yes, it's a little bit confusing, but as long as you remember these basic anatomical rules and kind of what boundaries exist, and if those boundaries are somehow perforated, what effect would that have? Then it makes this topic a little bit easier to understand. Okay, now speaking of these sort of layers, you've got a bunch of fascial layers, and you discussed this time and time again during anatomy, and to a lesser extent in imaging. It's very confusing, and I wouldn't say sit down and memorize the diagram on the left, but I think it's just a good idea to understand how all these things are continuous, right? It's not like the pelvis and the abdomen are kind of exactly separated from each other. In fact, the fascia is continuous everywhere. So you pick any of these lines, whether it's the dotted blue line or whether it's the solid green line, all of them continue on from the anterior abdomen down into the external genitalia, both in males and females, but they're just kind of named differently, especially in males because it goes for a little bit longer. So why is this important? Well, if you have a perineal infection, so something that starts around the external openings, right, on the bottom passage, those don't just stay there because the bacteria or the whatever's infecting there has a tendency to use the fascia to actually spread to distant regions, even sometimes going up to the abdomen. So for example, if it spreads along Colles fascia, which you can sort of see is labeled on the bottom section there, so that's the blue dotted line, it can then spread forward into the dartos fascia, so it then accumulates around. So if you just keep following that blue dotted line, it can go into the scrotum, it can then go around the penis, or in the female, the labia majora. If it keeps spreading, though, of course, it can go up right up into the anterior abdomen. So it can travel up Scarpa's fascia and cause an anterior abdominal infection. Hopefully by this time you would have controlled it, but if not, it's just going to keep spreading. If the perineal membrane itself is broken, so you can see that orange line labeled perineal membrane, it seems like it's a very solid sort of structure in the sense that if infection was to try and go posteriorly, it wouldn't be able to, which is why it always goes anterior. But if the membrane is somehow broken, you've now given it passage to go towards the rectum. So it enters into the ischiorectal fossa or fossae, which is where sort of you have the fat. You also have vessels and nerves traveling through, but you will essentially have a pathology that now spreads into the butt as well as the thighs. Okay, so that's very, very important. A very acute version of this is known as Fournier's gangrene. And it's a type of necrotizing fasciitis, which you will cover at some point. You may have already covered in first year. It essentially leads to all the tissue just dying, right? And this is not good when it's in the perineum, because you not only are affecting the external genitalia, the perineum, but it can spread way deeper than that, straight through, kind of eating through all the layers until it gets right into the pelvic cavity and then into the abdominal cavity. So sometimes, most of the time, this is actually fatal or leads to very, very bad morbidity. So it's a very important cause of concern. Okay, so just keep this kind of pathology in mind when you think about how perineal infections are so dangerous. Now, in terms of erectile tissues, I feel like I can't remember back to exactly this lecture, but I think you actually had an entire lecture just running through all the erectile tissues as well as the muscles associated with them. It's definitely a very interesting lecture, but also it can get a bit confusing. So if you try and keep it to the basic principles of what is shared between the male versions of these things and the female versions of these, you'll see they're exactly the same. It just looks a little bit more different in each of them. So when we look at the first column, you have the erectile tissues themselves. So you will have the cavernous tissue, and then you'll have the spongy tissue. So in this case, corpus cavernosa, corpus spongiosum. So the spongy tissue, as the name suggests, is kind of designed to be a little bit floppy. And in the male, for example, it's very important because it's going to be the thing that conveys through the urethra. So you don't want it to be something that, when it comes to having the erection happening, you don't want that to be something that becomes hugely rigid, because what's going to happen then is the urethra is going to get compressed and nothing's going to be able to come out, right? Then what's the point of the erection? Doesn't make any sense. So that's what the corpus cavernosa is supposed to be doing. So corpus spongiosum, corpus cavernosa. Same thing happens with the female erectile tissue. The actual external appendage is not as big, but you have the same kind of process. So instead you've got now the clitoris. So it has the cavernous part is the body of the clitoris, and then the spongy part is the glans clitoris. You also got some extra glands mentioned. So you've got the bulb of the vestibule, the crus of the clitoris, all these different things. Again, they're just kind of trying to say the same thing, which is that you have two components, a cavernous and then a spongy. If you just kind of map that across to, okay, I've got a cavernous and a spongy bit, for each of them, you have a muscle, essentially. So for both a male and a female pelvis, you'll have a bulbospongiosus muscle and an ischiocavernosus muscle. And that kind of just tells you where things attach. So like ischiocavernosus from the ischium, or I believe the ischial spine, but I could be wrong. Correct me if I'm wrong. The ischium to the cavernous tissue that we just discussed, right? And then bulbospongiosus from the bulb and then up to the spongy tissue. So same thing with the female pelvis. You've also got some extra transverse perineal muscles, so the deep and superficial. Those essentially just provide support. And the superficial transverse perineal muscle is important because it's the division between the urogenital triangle, which is more anterior, from the anorectal triangle, which is more posterior. So it's kind of what I mentioned before. When you draw the imaginary line, that's the transverse perineal muscle that actually is the physical version of that. Okay, so again, I kind of mentioned that where you see just pictures, it's not really that important to know exactly all the details. And the reason why I say that is because you actually cover the purpose of this anatomy or the function of this anatomy in physiology. The anatomy itself is not too high yield, right? So I guess we start from the left-hand side. We're looking at the outermost part of the male reproductive system, which is the penis and the scrotum. So the penis you can essentially divide into the root, the body, and the glands. But in terms of physical or clinical relevance, not that important at this stage. Once you go a little bit deeper into the scrotum itself, you now kind of got a cross section of the testis, in which you can sort of see everything that would have been mentioned in a physiology lecture, which you can have a look at as well. So they kind of link up. You've got your tunica albuginea, which is going to be the innermost layer of fibrous tissue attached to the testes, which then has those fibrous septations, which kind of divide up the testes into the tubules, so the seminiferous tubules. Here's where the sperm is produced. It goes through into the efferent ductules, up to the head of the epididymis. So it enters the entire epididymis structure from the head to the body to the tail, eventually up to the vas deferens. And then if we continue following that along, if we look at the diagram on the right, so you go up through the vas deferens, over the pubic bone, straight into the prostatic urethra, where it actually joins up also with the seminal vesicle to form the ejaculatory duct, which we will talk about in a sec. That goes into the urethra. Urethra goes through into the penis, so into the spongy urethra, and then of course it's ejaculated out. The scrotum itself has multiple layers as well, right? And I guess the main ones to really consider and talk about would be the cremaster muscle and the dartos muscle, which both have functions in making sure that your testes are at the optimal temperature for sperm production. So cremaster muscle is involuntary muscle. That's the one that wrinkles when you are in the cold. And the dartos muscle is a voluntary muscle, but still was not something that we always have like control over. It's just skeletal muscle. That's the one that pulls the testes up towards closer to the body where it's a bit warmer. This next slide is kind of the additional things that you want to be thinking about. So not directly related to the passage of sperm, but still very important. So the left-hand side shows you the spermatic cord and the contents. Obviously, the top one is the spermatic cord, so that's in the male. And then you've got a bunch of contents in there, and there's a few mnemonics to remember this, but either it was covered in a abdominal lecture or it is covered in the notes. So if you want to know all of the contents off by heart, feel free to look there, but it's not actually that important to really understand. I think the most important thing over the contents would actually be the layers of the spermatic cord and what they actually correspond to from the abdomen, as well as what they correspond to within the scrotum. Now from there, you've got as I said, the seminal vesicle. So you can see the seminal vesicle is quite small, joins up with the vas deferens, which came all the way from the epididymis and the scrotum and the testes. They both join together into one combined ejaculatory duct and enter or pierce through the prostate to enter into the prostatic urethra, which is where they expel the fluid or the semen. And speaking of the prostate, it's got a bunch of zones in it, right? So you've got a central zone, you've got a peripheral zone, and you've got transitional zone. You don't really need to know at this stage the clinical relevance of all of these zones, but one thing to sort of consider is that the peripheral zone is actually where you have most of the time prostatic cancers happening, right? Not so much the central zone. So that can make it easier to actually feel on a rectal examination because that peripheral zone is closest to the rectum when you're doing a digital rectal exam. An extra gland, very, very small one, is the bulbourethral gland. It actually contributes quite a bit to the composition of the semen at the very end. But the main function of the bulbourethral gland is to make sure that the urethra is clean, per se, for when ejaculate is supposed to go through, mainly to make sure that there's no acidic urine there that would kill any of the sperm that goes through. And then at the bottom, I've just got a slightly more detailed, but admittedly very small diagram of that spermatic cord going down and actually entering into the testis. So you can sort of see the pampiniform plexus, which is clinically quite relevant in your sort of bag of worms classic appearance of a varicocele. And just a thing to think about is if you know, do you have any idea of which testis is more likely to experience a dilation of this pampiniform plexus and why? So that's just one thing to kind of think about. Obviously, the pampiniform plexus has a lot more function in terms of venous drainage and making sure that the arteries don't overheat by allowing some way for that heat to then enter into the veins and escape the testes. So a lot of really interesting things there, but more talked about during physiology. In terms of anatomy, it's actually quite straightforward. Okay. So if you can draw out the diagram from testis all the way into the penis of how sperm goes and what additional vesicles or glands contribute, that's more than enough to know about this system. The female reproductive tract is also obviously very important to know. Externally, you've got a lot of different terms that can be used to describe different parts. Again, it's not something you'll be really openly questioned about, but I guess it's just a very good thing to understand if you're doing an examination, for example. So you've got the labia majora, you've got the labia minora, you've got the mons pubis at the very top, you've got the clitoris just underneath, or within the labia minora folds. You've got the vestibule, which is essentially just the openings of both of the urethra and the vagina. And then you've got the posterior commissure, which is essentially just there to sort of like a separation between the anus and the vagina. But when you have a traumatic birthing process, sometimes that posterior commissure can tear and you can get fissures and that kind of thing. So I guess clinically, in terms of that, it's an important landmark. You've also got the lower diagram, which is just showing you the anterior and posterior domes of the vagina. Posterior dome is important because that allows for a sort of collection of sperm when there's intercourse happening. So the sperm can stay there, and then it eventually gets taken up into the vagina. You've got the cervix, kind of, I guess, in the middle top diagram. You've got the internal os, which is kind of like a sphincter, external os, and then you've got between them the endocervical canal. So it's just like a transition between the vagina and the cervix, and the broader uterus. So then, obviously, on the right-hand side, you've got the uterus, and adnexa is just a term for things associated with the uterus. So it's important to know some of these landmarks. So you've got the vagina, the cervix, and then you've got the body and then the fundus of the uterus, if you're ever asked to describe or understand what those terms mean. Most importantly, though, is that kind of the fallopian tubes that come off the sides of the fundus. And they're kind of divided up into different parts. Again, anything that's long will be divided up into parts to make it easier to localize problems. So you've got the isthmus. We're going from sort of, I guess, proximal to the uterus to more distal. So isthmus, ampulla, infundibulum, and then fimbriae. So when you discuss in physiology, the fimbriae is the one that essentially collects the eggs as they come off of the ovaries. And then they get taken up and then kind of travel all the way through into the body of the uterus. But for our understanding, the ampulla is going to be the most important spot because that's where the fertilization will happen, unless, of course, there is an ectopic pregnancy. So where the egg or the fertilized egg kind of gets stuck in a part of the fallopian tubes or elsewhere, rather than actually, once it fertilizes in the ampulla, instead of just traveling down where it should be within the body of the uterus, it gets stuck somewhere else. Most of the time, the ectopic pregnancy happens actually in the ampulla. So what happens is that you get the fertilization, but it just does not want to move. It just kind of stays there. Other times it can go a little bit further into the isthmus and then it gets stuck and so on, right? So you've got all sorts of different potential places where this can go wrong. And it's very much an emergency because you essentially just have this growing structure that keeps on expanding, can lead to perforation, bleeding, sepsis, all sorts of obviously not very good things. An important topic that's kind of unique to the female reproductive system is all the ligaments that are associated with all of these organs. So there's so many that you could name, and I guess that bottom left diagram does a very good job of, I guess, summarizing every single one of them. But that's not to say that you need to know all of them. The three main ones that you need to know are the ones that essentially contain stuff. So broad ligament is an exception. It doesn't really contain anything per se, but it's the biggest one. So it has three components: the mesometrium, the mesosalpinx, and the mesoovarium. And you can sort of, like, if you kind of think about those names kind of more deeply, you'll see that they actually just describe exactly what they attach to. So mesoovarium attaches to the ovaries. Mesosalpinx, salpinx is just another term for the fallopian tube. So when people say there's salpingitis, that just means that you have fallopian tube inflammation. And then mesometrium is joining to essentially if you think about endometrium and that kind of thing, you can kind of see why it might have gotten that name, right? Because it's attaching to the main body. Okay, you've also got two other important ones that actually contain stuff. So you've got the suspensory ligament, which contains the ovarian artery. It also contains the vein. It contains the nerve plexus as well as lymphatics. So pretty important in terms of when you're potentially doing surgery. And then you've got the cardinal ligament, which is better shown, not so much in that same diagram up here, but in the bottom diagram here, you can see cardinal ligament. It contains the uterine artery as well as a uterine vein, and also provides some support to the wider structures. Okay, hopefully that makes sense. And of course, if you want to see the rest of the ligaments, feel free to look at the notes, but they don't actually contain anything. They just have different functions to keep this entire arrangement stabilized. Okay, and finally, just ending off on a little bit of the important neurovasculature. Firstly, the nerves. In this case, it's very important to talk about the autonomic control, because most of the things that happen down there are not actually controlled by us, right? So the autonomic nerves are derived from the hypogastric plexus. They travel through the urogenital hiatus, and then they go down to innervate different things in the external genitalia. A good mnemonic to remember, just very broadly, what the systems do. If you remember point and shoot, so point for parasympathetic, point meaning there's an erection, as well as the remission of the erection. Sympathetic, so shoot is sympathetic, shoot meaning an emission, as well as ejaculation. And also orgasm happens through the sympathetic system. Somatic nerves, or the main one is essentially the pudendal nerve, which you might remember back to the rectum and the anus. The external anal sphincter is also controlled by the somatic nerve, so S2 to S4. Maintains erection as well as aiding in ejaculation. Main thing it does essentially is it contracts those two erectile muscles, so the ischiocavernosus and the bulbospongiosus, as well as stimulating secretions from all the glands that we talked about as well. So it does quite a lot of things, but it's the one that we're sort of more in control of. Pudendal nerve is a sort of very good question for them to ask some things about. Of course, S2 to S4 is important to remember, but also the path of it as it travels through the pelvic cavity. So remember these 3 points. Essentially, that's all you need to know. First, it leaves the pelvis through the greater sciatic foramen. It then travels around the ischial spine, which we will discuss later is a very good landmark to identify it, and then re-enters the pelvis via the lesser sciatic foramen. So leaves via the GSF, travels around the ischial spine, and then re-enters back into the pelvis via the LSF. So you can kind of see that in the left-hand side diagram. You can sort of see it exits out and then re-enters back in, because essentially at the very end, it's going to not only control the motor functions of those muscles, but it also gives sensation to the external genitalia, as well as most of the perineum. So that's why it's a very important nerve that they can ask you questions about. Whoops. Yes, so now we're talking about the arteries. Now, I know I've not really talked about this at length, and there's a good reason for that, because it can get confusing. The thing that I found was helpful for understanding the arteries is actually just drawing it out yourself a couple of times. I'm not saying that, if you draw it out 4 times, you'll memorize it for life, but as long as you have drawn it 4 or 5 times yourself, if there's a very vague question about potentially the branches, you have a general idea of whether it came off this branch or that branch. So again, not to memorize it like hugely, but know the important branches at least. So the main blood supply comes from the internal iliac artery. So it supplies most of the pelvis structures. You've got the internal iliac artery bifurcating into anterior and posterior trunks through the greater sciatic foramen. So you can sort of see that. So you can see the common iliac bifurcating into external and internal. Sorry. And then you've got the internal bifurcating into posterior and anterior. The branching pattern is very, very variable. So I could have kind of listed this as being, okay, the posterior branches are this, 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 and this in this order. And then the anterior branches are this, 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 and in this order. But actually, it's a bit more complicated than that. And while those answers might represent the most common variants, unlike the other parts of the body, this is where a lot of variation happens. So the main way that arteries are named is not so much how they branch off, it's what they go to. So if you have an artery that you can follow along, you follow it, and it ends up going towards the rectum, you know that it's going to be one of the rectal arteries. If it's going towards the bladder, you know it's going to be a vesical artery. That's essentially how they are named in real life. However, kind of annoyingly, you won't be given a specimen that shows exactly where that artery goes to most of the time. So while I say that that's how it's named, it's not always the case. So sometimes you will have to either sort of make a good guess based on your anatomical knowledge, or if you just know the answer based off drawing this out a couple of times, that can help. But the way that I like to think about these, or the way that I like to think about it in second year was I like to think about functions more so than the branching, again, because it's so variable. So remember that there are two branches that go to the back or the posterior body wall. That's the iliolumbar and lateral sacral arteries. So both of them come off the posterior branch of the internal iliac up here. That's two down, right? Not so much important ones in terms of organs, but still important to know about. You then got four branches that exit the pelvis almost immediately. So you have the gluteal arteries, so the superior and inferior ones. You've got the obturator artery, and then you've got the internal pudendal artery. So most of those, as you can sort of tell from the name, they go towards muscles. Internal pudendal artery also supplies muscles, but it does a couple of other things. So most of these that exit the pelvis are just straight towards muscles as a general pattern. And then you've also got four branches that actually go down towards pelvic organs. So you've got the umbilical arteries, so towards the umbilicus. You've got the vesical arteries, which goes towards the bladder. You've got the uterine, and then you've got the middle rectal. I've already mentioned the uterine, but remember that the female pelvis has slightly different arrangement. So it can have the vaginal arteries as well. And they replace some of the arteries that you would see in a male pelvis. So I believe there's a good diagram in one of your lecture slides that goes over the difference, but it's actually, again, not that high yield to know. So if you remember these main terminal branches and are able to understand the concept that, you know, some of them are anterior, some of them are posterior, and they are named according to where they go to in the end, that's more than enough for this particular section. Oh, one thing I should mention, which I don't think I've done a very good job of here, is the relationship between the uterine arteries and the ureters. So you may have heard of the mnemonic that is like allows you to sort of understand the relationship, which is water under the bridge. So water under the bridge, essentially, if you think about what water means, that's going to be the ureters. The ureters are under the bridge. And, you know, while bridge doesn't really help that much, you know that that's going to be the artery, right? So that's going to be the uterine artery. Why is that important? Well, if you have a hysterectomy and you are trying to ligate some of these arteries, right, to prevent them from bleeding, firstly, it acts as a very good landmark. So if you can locate where the ureters are, you can follow it down, find the uterine artery. Easy to find it in that way. But it's also important because if you try and ligate an artery and you accidentally damage the ureter, that's going to cause a lot of functional problems for the patient. So not only is it useful, but it's also just very important to make sure you don't damage anything. So I haven't included that here, and that's probably a big mistake on my end. But I think if you're listening to this, just make sure you understand that relationship because it's an easy one to test, but it's also a really easy one to answer if you remember the mnemonic. Okay, remember that as I mentioned, there are lots of those arteries that just straight up exit out of the pelvis without really doing anything to the organs. And because you can't really trace them to an organ, sometimes it's very difficult to know which ones they are. But if you use some of the landmarks within the pelvis itself, you can easily differentiate each of them. So firstly, the superior gluteal and the inferior gluteal, they are separated from each other by the piriformis muscle. So superior gluteal, as the name suggests, goes above the piriformis because it eventually wants to supply the gluteus medius and minimus muscles. Another really interesting relationship that was mentioned in the lecture is if you kind of look at the sacral sort of nerve roots, you look at L5 and S1, I kind of labeled them here in the diagram. They form a V shape, and though that superior gluteal artery just kind of passes through that V. So that can be really helpful as well. But regardless, below the piriformis, you then have the inferior gluteal that goes to the gluteus maximus. The obturator one is very easy. So it just goes straight through the obturator canal, if you know the boundaries of that from our first lecture on pelvis anatomy. The internal pudendal is a difficult one because if you kind of have a look at the internal pudendal artery over here and the inferior gluteal artery here, you can see they both travel together. So how do you tell one from the other? Well, remember what we said before is that the internal pudendal artery, yes, it exits out of the pelvis at one point, but then it actually also comes back into the pelvis. So if you remember back to the pudendal nerve exits out the greater sciatic foramen, and then it re-enters back into the lesser sciatic foramen. internal pudendal artery does the same thing. In fact, they all kind of the artery, the vein, and the nerve, they all travel together in a bundle. So they'll have the same landmarks that you can follow. Whereas, of course, the inferior gluteal doesn't do any of that, right? It has a very straightforward path out of the pelvis. So that's very important to remember. And then finally, you had a couple of slides on the lymph nodes. And again, the two diagrams on the right, they're very, very complicated. You don't have to memorize at all the specific organs that drain where and what, right? You don't have to really remember that. So I wouldn't encourage you to kind of, I don't know, make an Anki card and try and memorize all of these. But if you know the general patterns, it's very easy to deduce where things will drain, especially in the context of tumors. So the internal iliac nodes, they drain all the internal pelvic structures, as the name suggests. So that includes things like the prostate, but of course over here you've got other things, middle part of the rectum, part of the cervix, and most of the vagina. Inguinal nodes, those drain the external genitalia and the perineum. Whereas, and more specifically, the superficial group will drain the scrotum or the skin of the perineum. Again, it's very easy to remember because the superficial nodes will drain all the superficial stuff, which is the skin. The para-aortic nodes, now this one is very important. So these are like on either side of the aorta. So they're very, very far away from the pelvis, but they still drain some pelvic structures because remember, things like the testes and the ovaries, they actually start way up in the abdomen, the posterior abdominal wall, before they then get dragged down closer to the pelvis. In the case of the testes, they get dragged down much, much further, but they still maintain their embryological origins. So another classic example is the fact that the testes and the ovaries, their blood supply comes directly from the aorta and very high up. So the same thing applies to the lymph nodes. They will drain straight into the para-aortic nodes, bypassing all these other nodes that we've talked about. And the external iliac nodes, they drain structures that are more superior, I guess, or those that are a little bit closer to the inguinal canal. So that includes the ductus deferens, also part of the cervix, the uterine body, etc. So if you remember these four ones, and I think the two most important to remember would be the superficial inguinal nodes and the para-aortic nodes. Those are the ones they can ask you most questions about. Okay, I think that's all for today. I know it was not as long as you'd expect because obviously the pelvis contains a huge number of organs and each of those organs have their own unique characteristics. But in terms of things you like really, really need to know, I think this is 100% enough to cover you for those questions. I've tried to keep it very simple based off just sort of feedback from previous anatomy lectures that we've given. While you guys have been really awesome with feedback and things like that, and you seem to have appreciated all of those different concepts, I think we all universally like things that are a little bit shorter and to the point. So hopefully this kind of achieved that. Let me know if you kind of like this style more or less than the previous ones. And of course, you have those notes as an extended resource. So if you read through this and you think you're still wanting to learn more or something has been mentioned in the lecture and you just want to cross-check whether it's something that's relevant or something you need to know, check the notes. If it's there, then it's just a good idea to have it in the back of your mind. So this covers all the main things. Okay, that's enough rambling from me. Enjoy the rest of your week. And as always, feel free to message us or myself directly if you have any questions about this content. Best of luck, and I will see you next week. Bye-bye.